Good afternoon, ladies and gentlemen. Hope you all will agree with me for the fact that the availability of competent groups of medics in the battlefield and availability of effective and efficient casualty evacuation system in the field are as effective as of having brave, well-trained, skilled professional soldiers with modern equipment for the success of a military operation. It is not only by saving the lives and limbs of injured soldiers, but more importantly, by developing a confidence and by boosting their morale by the presence of someone who could be trusted upon and who could help them, who could look after them if they were injured. Providing such service is not as easy as we think superficially, especially with limited resources, both human-wise and equipment-wise. Within the next 20 minutes or so, I am going to present you how we face the challenges initially and thereafter how we accomplish the mission to the utmost expectations. The sequence which I am going to follow is as shown in the screen. The Sri Lanka Army Medical Corps is a proportionately small organization when compared with the medical corps in the region. You may be surprised to hear this, ladies and gentlemen. By 2006, we had only 118 medical officers and 3,200 men, of which only one-third of the medical officers and half of men are available to employ in the field. Others are employed in static military hospitals and other important military medical establishments. Having recognized the problem in advance, we were able to address the issue timely. We trained a group of selected infantrymen from each regiment as regimental nursing assistants, who were given complete training in combat light support course at our training centers. By mid-2006, we were able to train almost all special force personnel and commandos in advanced combat life support course too. All our young medical officers were given basic training in basic anesthesiology and basic surgical care. Additionally, all our medical officers, nurses and paramedics were given special training in handling and management of victims of chemical exposure. We mobilized most of our male nurses and nursing assistants from non-operational areas to the operational areas. With the commencement of the operation, we mobilized all possible military medical officers from static military hospitals in non-operational areas to the field. Those vacancies in the hospitals are filled with civil medical officers and civil nurses borrowed from Ministry of Health. The Army base hospitals and the civilian hospitals bordering the battle zones were strengthened, well equipped, and additional surgical teams were obtained from Ministry of Health. All those things are done in such a manner so that military surprise was not compromised. Ladies and gentlemen, let me explain you now our deployment in the field. The areas of responsibility were divided among the 4 medical battalions we had, one of which was Volunteer Battalion. The 4th Battalion was deployed in the Jaffna Theatre. The 3rd Battalion was deployed in the Vanni Theatre. The 2nd Battalion, which is the Volunteer Battalion, was deployed in the Eastern Theatre. The 1st Battalion was responsible for the rest of the country while supporting other theatres as well. The main military hospital is in Colombo, which has a bed strength of 650. There are 4 army base hospitals, one in Palari, that is in Jaffna, one in Anuradhapura, one in Panagoda, that is close to Colombo, and another one in Diyathalawa, that is where our military academy is. There are 4 field hospitals. One was in Mirusuville, that is in the Jaffna Theatre, one was in Trincomalee, that is in the Eastern Theatre, and 2 were in Vanni Theatre, those are the Mana and Vaunia. Additionally, We had affiliated army wards in 6 civilian hospitals, namely Anuradhapura, Polonnaruwa, Hinguraggoda, Velikanda, Ampara and Kandy. We established military nursing aid posts in all major civilian hospitals which receive casualties. That is to coordinate the casualty management process and to look after the welfare of the injured soldiers. Considering the terrain and the nature of the humanitarian operation, we had to provide an ADS, MDS-based medevac system, which I am going to unfold now. The regimental nursing assistants and nursing assistants were deployed at platoon and company level who initiated the treatment of casualties. They were capable of applying proper dressing, giving intravenous fluid, intravenous analgesic, that is painkillers, and splinting of fractured limbs. Then the casualties were sent to battalion headquarters, where a team of medics consists of senior staff nurse, male nurse, and nursing assistants took over the task. The triage was done by the senior staff nurse. Their responsibilities were to maintain airway, breathing and circulation, make sure that the wounds are properly dressed, analgesics were given, hydration is maintained, fractured limbs are properly immobilized, and the active bleeding was controlled. From the battalion headquarters, these casualties are transferred to advanced dressing stations by ambulances, trucks, tractors, and sometimes by APCs. ADS was located at the brigade headquarters level and was manned by a medical officer who was supported by male nurses and nursing assistants. At the ADS, triage was done by the medical officer, and their responsibilities were to maintain airway, breathing and circulation, continuation of antibiotics and IV fluids, giving tetanus toxoid, blood transfusion if required, stabilization of fractured bones, make sure that all the bleeders are controlled, perform life-saving minor surgical procedures like chest drains, leucothyroidectomy, thyroidectomy, etc., and stabilization of patients to transfer to MDS or main dressing stations. Transferring casualties from ADS to MDS was done by ambulances and trucks. MDS was located at divisional headquarters level, and there was a senior medical officer in charge who was capable of giving anesthesia and performing all life-saving surgical procedures. He had nursing and paramedical staff to assist him. MDS was well equipped with all necessary medications and basic equipment to handle any type of medical or surgical emergencies as well as their complications. Facilities for monitoring vital parameters, portable ventilators, and mini blood banks were available in the MDS. The triage was done by the senior medical officer. Their responsibilities were reassessment of the patient, make sure that the airway, breathing and circulation are maintained, maintain all vital functions, continuation of adequate hydration, antibiotics, wound debridement, control bleeders if there were, blood transfusion if required, and stabilization of fractured bones and limbs, perform limb and life-saving surgical procedures, and stabilization of patients to transfer to army-based hospitals or local hospitals in the region. Depending on the intensity of the battle and the geographical conditions, these dressing stations were shifted within the tactical area of responsibility of the divisions. There were occasions we had to provide additional medical team and staff to the battalion headquarters, ADS and MDSs. There was a good communication system in each dressing station, which helped them not only to convey relevant information to higher headquarters, but also to get relevant expert opinion from Colombo in difficult situations. Evacuation of casualties from MDS to local hospitals or army-based hospitals was done by helicopters, mainly by Mi-17 and Bell 212. Sri Lankan Air Force pilots untiringly operated round the clock in the casualty evacuation system. At the ABH,